my background, I did lab research in ctDNA during fellowship. So I was a postdoc at the lab for 1.5 years. So ctDNA, there's a few things. When we talk about liquid biopsies, there are assays that they measure somatic mutations that are coming from the tumor. And that's relevant for you to know if a patient has a mutation that is driving that cancer, and then you can give them targeted therapy against that. So you don't need to wait on a tissue analysis of those mutations for you to act on the treatment of your patient if you find that on a liquid biopsy. And the FDA here in the United States has approved 2 platforms, Foundation One and Garden 360 last year in 2020, that we can use in practice across the country. And they have been used outside the United States and in here even before the approval. So the whole purpose of this is that those tests, they come back in 7 to 10 days. So you have results much faster, than a tissue comprehensive genomic testing that you have to send the material to the company. Sometimes if the tissue, the biopsy was collected in an outside facility, it has to come to your facility to then go to the company, to then get analyzed. So you're looking at 4 to 6 weeks. Nobody wants to wait all the time. So liquid biopsies have changed a lot because if they provide us the information that we're looking for, we can act on it. But now, if we don't find a somatic mutation on that liquid biopsy and we have a high suspicion, you really think the patient has a driver gene that is providing this cancer to grow, giving this cancer growth, then you have to do the genetic testing on the tissue sample. Now, there's a lot of research on ctDNA regarding can this be used as ways of knowing pathological response, for instance, for patients undergoing surgery or neoadjuvant chemotherapy or neoadjuvant immunotherapy. Does that correlate with pathological complete response? And now there's data that we're finding that there is a correlation in other solid malignancies. We can see the changes in ctDNA. We see that, or changes in ctDNA tell us that a patient's disease is responding to therapy. So there's several ways to use that as a predictive biomarker and as a prognostic biomarker. Now, the next level of liquid biopsies is for lung cancer screening, or early disease detection. In my expert opinion, I don't think the somatic mutations will be enough because not all patients have somatic mutations that the panels that those assays are looking for have in the coverage, is not enough. Second issue, for you to detect something, you have to have DNA shedding from the tumor cells into the bloodstream. If you don't have a lot of disease, like early stage disease, you may not have enough DNA floating around, so you won't be able to detect, not because there isn't DNA from cancer cells, but because there's not enough. So sensitivity becomes a problem when we try to translate the gains of this technology in late stage disease to early stage. So there are new assays under development that look into other biomarkers like protein expression, methylation, that you probably will have to use in combination with the mutations that we look for nowadays with these platforms, so we can actually translate that to early disease detection or lung cancer screening.